Hello and welcome to another episode of Intellectual Calisthenics. Today I am truly honored to have as my guest Dr. Latika Gupta. Dr. Gupta is an assistant professor in the Department of Clinical Immunology and Rheumatology at the Sanjay Gandhi Postgraduate Institute of Medical Sciences in Lucknow. And she is also the social media editor of the Journal of Clinical Rheumatology and the International Journal of Rheumatology. Today, what we are discussing is Dr. Gupta has recently published, actually, it's two studies. One is in, in the way of being publishing, and she's going to share her experiences with tele-rheumatology in India. So given the COVID pandemic, obviously telehealth has taken a lot of, has become very important for everyone. I've been using telehealth for a while. So Dr. Latika, please will you say a few words about yourself? You have so many different hats. Where do you want to start?
Thank you, Dr. Kar, for the very kind introduction. Um, uh, I joined here, I've studied in Lucknow, and I joined here, so it's been 7 years now at this institute. And yes, the COVID-19 pandemic has changed things for us. We have began teleconsultations, and myself being into social media editing, I am a strong proponent of the use of technology in science, and I feel there are many ways we could put it to use, and as we say, adversity makes us grow. So maybe this is an opportunity, and we might thank ourselves for what we gained during this period at some point.
Thank you. So you are going to walk us through your this particular study that you have done. So was this study done in at the Sanjay Gandhi PGI, or was it in other places in India as well?
No, it was limited to our center.
Okay.
So it all started um, just by a small discussion between all of us, our team, because the COVID-19 pandemic was unexpected, as we all know. And as physicians and even as human beings, we all did feel very vulnerable. And we expected that our patients would probably be feeling no better. And we were concerned about them that with the sudden lockdown which came on in India, they would probably have certain fears, not only related to the COVID pandemic, because a lot of them are on immunosuppressant medicines, which increase the risk of infections, although it wasn't clear at that time point if it increases the risk of COVID-19. And many of them were on drugs, and which they might not be able to get their refills because of the lockdown. And we were worried that they would definitely flare up if they discontinue their medicines. And there were also logistic issues because some of them are on infusions, so they need to come to the hospital regularly. And this overnight fame of hydroxychloroquine, it did not really do any good because so most of the pharmacies actually ran out of the drug, and our patients who had been on them for years struggled to get a supply. And
Mm-hmm.
the fact that later now, with all this controversy, they have added, they have more trepidations about taking this drug is another story. So, so we thought that maybe we could just get in touch with them, although we were ourselves really clueless as to what next. But we thought the least we can do is offer them some mental support and tell them to just stay put wherever they are, follow all precautions, and continue their medicines. So this was all we started out with. And in fact, our department, rheumatology, we started teleconsultations much before they began formally at the institute level. So we pulled out records of patients and those who were scheduled for appointments. We called them up, and just to pacify them, give them some support, and ask them to get in touch maybe a month later and report if they had any acute symptoms. So that was the initial intent. But during this period, we were also curious as to what exactly these patients were feeling. So we did conduct a short survey in certain rheumatic diseases. Like this was one disorder called myositis, and we served this questionnaire on social media platforms, and we did find that they had so many prevalent fears, which was expected. So, most common being like contracting COVID or COVID 19 in the family, or a worsening of the disease. They were also having general worries, and confinement is not easy. We all know that. So, that had was an added stress factor. And some of them were waiting for crucial test reports, or just not being able to meet the doctor was some of the concern. And
So,
even
Dr. Gupta, one clarification: what is IIM? So, those who are not rheumatologists will.
yes, so I'm sorry about
No,
that.
it's
So
okay.
this is idiopathic inflammatory myositis.
Okay.
So it is a rheumatic disorder
Mhm.
which affects the muscles,
Yeah.
and it is autoimmune in origin. And in the acute phase of the illness, the patients would have weakness and pain in their muscles.
Mhm.
They would be unable to do activities of daily living. And a
Mhm.
certain population can also have skin involvement, lung involvement, and arthritis. So it is a severe and disabling disease because mobility is completely hampered. So, so this was the group in which this particular survey was conducted, and we did find that self-reported disease status, it was affected in a large number of people. So although 60% said okay they were doing fine, some required an increase in medications, some had some symptoms which they were not sure what they were, and some had symptoms which are unrelated to the disease. Few did require hospitalization. So definitely a lot was going on here, and this population we did need to reach out to, despite the uncertainty and the unfamiliar situation.
So, one question: the hospitalized patients. So, since you were talking to them on the phone, right? Or was it a combination of phone and video? How were these consultations being done?
So this group of patients was actually, we circulated the questionnaire on patient support groups. So this was reported from all different countries all around the world.
Okay.
And this particular data set is not limited to India. And they were seeking care at their respective local centers.
Okay. So obviously the demographics would be quite diverse, because my question was about the hospitalization. Did you kind of triage the patients, at least in your center? You probably won't know about the other
Yes, I
centers.
think we will come
Okay.
to that in a minute.
Okay, great.
And apart from that, patients did have face logistic challenges. Like almost 1 in 5 could not procure drugs. They were either out of stock, or they could not travel to the pharmacy, or had to depend on others, or get delivery. So a lot of our population is also rural based, who might not have access to internet, or might not be technologically um, able to do all this. So the sad part was a lot of them had to postpone infusions, although only a handful were on infusions. But within that group, a lot of them had to delay them, which inevitably would lead to problems and even physiotherapy sessions. This is particularly important for this disease, that
Mm.
they were disrupted in nearly 1/3, which is a big number. So with that background, we set out um, with this teleconsultation services at our institute, and this is a short summary of the profile of cases which we have seen in the past 5 weeks, so over 20-day period. And we have looked after around 508 patients who so the distribution is more reflective of what we see in our normal clinics. So rheumatoid arthritis and spondyloarthritis are two very common disorders in the population, and we did hear back from them as well. Although some groups like osteoarthritis is fairly common in the general population, but they did not really call up that frequently, suggesting that certain diseases may require less care
Mhm.
as compared with some others. And here is the role of triage that comes in, which we'll talk about in a minute.
Mm-hmm.
And some diseases are pretty rare, like vasculitis, systemic sclerosis, or lupus. So these are rare, but we did see a lot of them calling back, suggesting that they probably need more care and more frequent visits and frequent checkups. Also, it might also be a representative of our tertiary care center. So there's a referral bias. So definitely we see more of those rare disorders
Yeah.
seen with GPs. So if you look at the advice which we offered to them, you can see in a large
Mm-hmm.
majority, they were just advised to continue the same treatment. And um, another one thirds, nearly one thirds, we were asked to review with investigations. So normally, if these patients were to come to our clinic, um, so this being a tertiary care center, many of them travel long distances. It is normal and expected for them to travel all the way from like 12 to 14-hour journeys in the train and then the bus, and some of them are not financially stable, so they have to use public transport, and if not, then they have to arrange a vehicle which costs them a fortune, and then they need to stay for a day or two to wait for the test to come back and then have a repeat consultation, which amounts to a huge financial burden to the family. And as you would know, like in the United Kingdom and Australia, it is more of a GP based uh, GP centric services where patients with even rheumatic disorders, they visit their GP 3 monthly, and if they have a flare up or something acute which requires immediate intervention, then they visit the rheumatologist. Otherwise they visit annually, where we take care of all the other services like bone health and lipid profile, everything else. So I feel like that model is really something we could get to in India, and consultations might be the bridge towards
Mm-hmm.
that, because unfortunately the diversity in our country and the population burden and the structure of medical care does not really allow for a very structured referral system. The patients are free to choose the practitioner and the hospital, and they could be consulting three different people at the same time, or at the same time, they may also not be able to contact even one GP, because there is a lot of hesitation by the GPs in catering to this population, which has a complicated diagnosis, because it has implications in terms of litigation and complexity of management. So we need a network of health services where the GP can get in touch with the specialist. So
Mm-hmm.
the GP can be guided by the specialist. And I feel the penetrance can really be improved only by teleservices, because our country is huge, and it'll take a very long time if we actually try to physically penetrate all those areas and get to them and offer them advice. It will take us another
Yeah.
century.
And the other thing is, from Dr. Agarwal's interview in the last video, I understand that there are just 1,200 or 1,300 rheumatologists in India. Am I right?
Yes. So,
So
yeah. Please.
that is another important factor. Now, something interesting I noticed is about 70% of the patients could do without actually coming. So they were just continuing the same medication, and they just, like, for review of lab work, why would they need to travel really? Because this system was not there before. So even for the only thing that people need is essentially when they have to show up for a physical examination. And as you rightly pointed out, even in countries like Canada, and I'm not a physician here, but the system is, first people go to the family doctor. Then if the family doctor thinks it is necessary to refer them to a specialist, only then can they go to a specialist. Versus in India, patients can go directly to the specialist. They can consult three specialists, four specialists at a time. So that is, again, sometimes I think it does cause a little bit of a difference in treatment as well. Am I right?
Yeah, and although I would not like to downplay the importance of a formal physical exam, because there are things which would come up only when you see the patient right in front of you and you can examine. There are a lot of things which can be missed over a teleconsult. But yes, I do agree that there can be a certain triage algorithm in place and we could definitely help with some support, get some help from the GPs. In fact, even in the intervention group, if you see here, which is nearly one third,
Mm-hmm.
almost 68% just required dose titration.
Those,
So it is like the patient had a minor flare and we just had to increase the drugs a little bit, or had a minor was improving and then we had to taper the drug. So this is something we could really coach the GPs and form a team together for quality care, because normally in our clinics, we see at least like 30 to 40 patients in a span of 5 to 6 hours, which is huge.
mhm.
So, so while I look after one patient, we have 10 others waiting outside the door, and sometimes we have intermittent, disruptions where someone walks in. So patient privacy, I feel, and the comfort of talking to your doctor, somewhere it's far from perfect, I would say.
Yeah.
And I did experience this while delivering teleconsults. We just started out with a very minor motive of just telling them to continue and not worry. But I realized that some of the patients really could talk about their inner fears and their darkest thoughts in this 5 week period. And maybe because it could also have something to do with the cultural norms in our society. So people travel with their family, and then sometimes they can be repressed. They cannot talk in front of the
Mhm.
other family member. Even when you send them out, they are in a hurry. They know there are 10 other people waiting outside. They're not in their comfortable environment. Like we talk about the shrink couch, which is a very important setup for a good connect. So I did feel that, ironically, we expect teleconsultations to offer less connection, but there might be a difference in terms of the first visit versus a second or a third, or someone who's been seeing you for a long time and they already have that connect with you. They can connect very well over the phone, or maybe even better at times.
Mm-hmm. So again, you were talking about the triaging. I think that's the next slide, is it?
Yes.
Yeah.
So first, we did try to look at the patient satisfaction levels,
Mhm.
because we were not sure about this approach at all, and much to our surprise, and we were delighted to see that it was appreciated. And despite the minor technical glitches which we are bound to experience, they did like both the consultation and the voice quality. And whether they should continue it in the pandemic, post-pandemic period, 70% agreed to that.
Agree to it.
So yeah, so and we did ask patients about the maintaining the continuity of medical care in the post-pandemic period. So the preferences only a minor population. So this data is from across the world, and so they felt that home and hospital services. Very few people wanted either visits to the home or hospital visits, and most of them wanted teleconsultations. But as we can see, audiovisual was the most preferred means.
Yeah.
So I do have thoughts about this as well, because now if we first step is like moving towards teleconsultations, but once we start doing it as a routine, seeing every patient on video may not be possible. So
Mm-hmm.
in fact, the India, the MCI recently brought out these guidelines in India uh, about teleconsultations and the norms. So they did talk about video. Certain drugs can be prescribed only after a video consult. So I do think there could be some sort of triage here as well, like those just for drug refills or just a
Yeah.
routine checkup. Maybe could do with just a voice consult. Or I think I personally do feel WhatsApp does well in this part of the world because everyone has it,
Yeah.
and it offers you the interactive and user-friendly um, platform where you can share picture. You can also have a video call if you want, or just stick to voice. But of course, data protection is another area which needs more sorting, because there can be serious ethical concerns with violation
Yeah.
of any patient data safety.
So, Dr. Gupta, one interesting thing that you mentioned is the recent teleconsulting document that has come out. So, one of the biggest advantages, I've been using teleconsult for a while, and back then they didn't have kind of watertight regulations in the sense that what was allowed and what wasn't. But interestingly, now that document says that you can do a consult on WhatsApp, Google Meet, Skype, Zoom, anything. And I don't remember noticing that there is any specification about a HIPAA compliant platform. So here in Canada also, they changed some rules when the COVID-19 situation came up. The privacy issues remained, but they made it like the billing and all those things had changed. So yes, enabling WhatsApp consultation legally, because first of all, as physicians, we don't want to go on the other side of the law. So, but legally, when that became allowable, so that was of course very convenient. But one of the things, and again, because you are at an academic institution, one of the things that the document stipulates is that patients' consultation has to be recorded. So some people got confused and they thought they had to actually record the video. And I was thinking, where am I going to host so many video consults? The privacy concerns and all those came up. But it wasn't the video recording, it was just recording the consult. And you already use an EMR, if you had mentioned that, at your institution. But I think that is another challenge with many Indian, particularly small private practitioners. Not everyone is using an EMR. So EMR, it's easy to record everything and not have the paper documentation, because if it is on paper, then again you have to scan and send, and again all the privacy issues that you talked about would come up. So those are some of the challenges. Yeah, please go ahead.
So definitely, this is something which we need before we move further on to making teleconsultations a routine, because we don't know how long this pandemic is going to last, and definitely we'll need these for a while. And but we use the electronic health record system, but we need a unified EMR
Yeah.
before we can form that network with GPs, because to simply to avoid the repeated effort of going through the history and the background, we need a unified system where you can just glance through it and get an idea of the entire picture, what this patient has been through, what we're wanting. And also, I really like it, like the Epic system. I think you're using that in Canada as well. So you can have the instant messaging based service, which is part of the system. So the patient can send you pictures, but there is no ethical violation in the sense that you have linked identifiers for login. So if there is any violation of patient right, then that can be easily tracked. So we do need that kind of a system before we can move further onto this.
So one recently we had, I was a part of a summit called Health 4.0 Summit. So Health 4.0 is what is health going to look like in the next 10 to 20 years. And there is a concept of a digital twin. So a digital twin is like an electronic version of a patient. So the concept of digital twin starts actually from the engineering and industrial digital twin concept. So what you were talking about, this interoperability and the fact that all these are in silos. So how does one silo communicate with the other silo? That those are big challenges that have to be overcome. But then there are lots of things happening in the technology world, and that's what makes me so excited, because technology is the great leveler. Whether it's a country like India and the rural population, I have a belief that if someone can download an app or use WhatsApp, they should be able to have a medical consult. Right? But
Yes.
as you rightly pointed out, it will always be a combination of both in person as well as teleconsult, because some things, like you said, and I'll come to that part if you don't run out of time, about the thing of how can you monitor patients at home. So
Yeah,
anyway,
so we will
go
be
ahead.
coming to that. But I do think just a word about the things which particularly need sorting out before we go big on this is the document in India legalizing teleconsultations is still quite preliminary. We need a detailed list of
Yeah.
drugs. Like our rheumatic drugs are all immunosuppressants, which carry significant risk of side effects. But then these patients also require those. So we need more clarity on the kind of drugs, like typically all the names which can be prescribed, because some drugs do require video consult before they can be given to a patient. And also more fair clarity for better, like situations where litigation is an issue, or even reimbursement. So I don't know where patient reimbursement stands right now. If they pay for a teleconsult, how clear is that process? And sometimes patients need a medical certificate, or they want some sort of a what we call as Kamdenu services here. It's like getting funds or getting grants for health from certain central agencies. So we don't know how streamlined that pathway can be through a teleconsult, because I have been getting requests for those and I have been sending some of those out, but I don't know if those documents will be accepted.
That's a very interesting perspective. So, another thing what you brought up is about the payment considerations. So, because you are at an academic institute, I assume that patients don't have to pay for their consults. Do they have to pay?
No, so this is a very different setup compared with the most of the others in the government sector. So everything is paid at this institute, although it's less as compared to the typical private sector.
Yeah.
But yeah, even a consult, it's a minimal pay, usually like an annual fee kind of a thing.
Okay.
But yeah, it is there.
Okay, so that is one of the areas where I feel in India there's a little bit of challenge for, and I'm talking about not someone in an institution like yours. You have everything in place, but for a small practitioner in a private practice, what I felt is most of them are used to getting paid at the consult. So that is a physical visit, and they pay for the visit there. Versus there are so many ways available now where patients can actually prepay for the visit. So my practice, patients have to prepay for the visit, otherwise they don't get the appointment. So this is one of the concerns a lot of my colleagues I know have, is how will I get paid? Because if I do the consult, and obviously the private practitioner cannot be expected to do a free consult, but if I'm going to do the consult and then ask for payment, what if the patient decides not to pay me? you know, so that is one area where we need some. Again, many of these payment services, they also have deduct a certain amount from the payment. So naturally, doctors have to think. If I'm going to charge this much of money as consultation, and even 3% of that goes away, because in India it's not like everything else. We don't have a whole lot of support for anyone. So money does make a big difference to everyone. So I think that is one area. And I know that there are some payment platforms available now. There are a lot of companies getting into that now. So that is not relevant for an institution like yours, but that is something relevant for anyone else getting into teleconsulting and working in a different way. So this is very interesting. Your survey was very good, excellent, and you came up with so many interesting information which probably you would have had no idea about if you didn't do this survey, right? And
Yeah.
actually, indirectly, if there had been no COVID pandemic, also. So
Yeah. So we did. It has been a learning experience for us, and we have been. We got many fresh ideas after we started it. Something
mhm,
started off a small thing. In fact, now I think that this is a platform which could ensure borderless care, as I say here, apart
mhm,
from community outreach, where we are already trying to get. Although still we have some minor hiccups in the form of like illiteracy, people not having access to the internet or not having access to smartphones. We do have that rural population which is underprivileged, and definitely something can be done as part of a bigger effort to help that population. And for those who are already on the platform, maybe the next big thing in the next 10, 20 years time could be borderless care, like people seeking an expert consult of a person who looks after a particular disease, or a specialist from India seeking opinion,
yeah,
uh, formal opinion. We do that still at times for challenging cases, but this could be more structured
mhm,
and
yeah,
would give greater credibility to the effort. Apart from that, of course, Google is into like using this big data for
yeah,
data mining. Although again, this is an area which is relatively gray and needs to be sorted out in terms of the legitimacy of it. And it will reduce burden of healthcare. I have never felt so relaxed during a patient consult as I have felt
mhm,
during this period, solely because earlier we were doing so much. But sometimes you're doing so much, but you feel you're just not doing enough. You're
Hmm.
not just doing good enough, because you're doing a lot, but it's not satisfying enough, because
Yeah.
the quality goes down once the quantity goes up.
Yeah.
I do think that with a reduced burden, especially a purpose of a tertiary care center is to deliver quality care,
Yeah.
complete and wholesome care, which we can do only as a team. And a team can be formed only with a GP, with the patient, if there are healthcare workers in the community, and of course we have resources now, so many online resources. So interestingly, I found it very convenient to so yesterday itself I had a teleconsult by a patient who happened to be a doctor himself and had a disorder, had some pain issues which were there was central accentuation of pain. So definitely allied health services and physiotherapy, mindfulness, these are things which are more likely to help in these situations. And it's so easy when you're e-connected to share those links and those
Yeah.
resources. So internet is a boon, and we have so much out there, and we just need to streamline, curate the information and deliver it to the right crowd. And
Mhm.
this model is also financially sustainable, because in India, a lot of times patients cannot afford a
Yeah.
physiotherapist or a yoga class or something like a therapist,
Yeah.
or get nutrition advice, which is, I think, vital to good and wholesome care.
Oh,
So telehealth can help out with that. So no one knows that better than you, and
absolutely.
I really feel that this is something which we should get onto.
Oh, absolutely. Just one this thing about the artificial intelligence. Yes, big data is going to make a big difference to patient management, and particularly from countries like India, where given that the population is 1.3 million, we do not always have like very high quality data coming from. Like for example, if you look at the world of genomics, I mean, worldwide the population of South Asian origin is about 17 or 20%, but in the genomics database, it's, I think the last I checked, it was for like 0.2%. So
Right.
obviously, a lot of things like, in your world, pharmacogenomics would make such a big difference. So yes, the medicine of the future is machine learning and AI. But the other big, challenge which I find that is going to come up, particularly in India, is because you have an EMR. So your data is kind of clean, right? So, high quality information will come from high quality data. But a lot of hospitals are still using pen and paper. you know so to translate that pen and paper data into structured data to for us to get really good insight, that is a really long process. So but then I think sometime or the other we are going to reach there. What do you think were some of the pitfalls or some of the potential challenges that can happen from this?
Yeah, one is definitely regarding AI. I do think not just India. India is, of course, far behind, but we can definitely catch up in terms of numbers whenever we'd like to. But yes, wherever there's human effort, it's full of imperfections. And I do expect AI to be a big supportive mechanism in terms of healthcare, but for it to overtake everything and be the sole thing out
No,
there, I wouldn't really believe in
no. As Dr. Eric Topol says, AI is
that.
going to make us better doctors.
Yes, yeah, I follow him too.
Okay.
So definitely there's some pitfalls, and we need to be wary of being misinterpreted, because virtually it's easier to misinterpret someone. So we need to have more clarity in while dispensing our ideas or advice, because it can really wreak havoc if, for example, we prescribe methotrexate once a week routinely, and it will be any rheumatologist's nightmare if the patient started taking it every day. Uh, so they can have severe pancytopenia and face the risk of mortality. So data ownership is another thing. Like, of course, now we are under the aegis of this institute, we are protected and privileged lot, but for the practitioner tomorrow, it's just about it takes a moment for the patient to feel cheated or have any sort of negative emotion, where that data ownership, or if it is really violated or if there's a misunderstanding, it can spell trouble for the doctor. And of course, patient rights need to be respected. and it is extremely essential to be mindful of that. So I think a formal training of teleconsultation should be in place before everyone embarks on it and embraces it wholeheartedly. And there are technical failures, as we would have heard, like Zoom itself has fallen into disrepute, although I still really like the platform. But so this is something we need to work on, and maybe we need help from our uh, engineering and other allied specialities for that. And there are instances of incivility, and which can be sometimes unpleasant and
Okay.
difficult to handle. Uh, um, they can be by mistake or they can be on purpose, and these can be quite challenging to manage at times. So, in fact, I recall one incident on recently. I was able to, thankfully, because of this pandemic, I was able to get in touch with my patients, and it led to the formation of a patient support group, which was a really positive thing, something I wanted to do since a long time. And finally, 2 years I'd been thinking, but life had been moving really fast. And finally, when it slowed down, and because I personally feel that patients, they the kind of mental support and understanding which they can offer to one another will be any day beyond what we can offer. So
Absolutely.
I feel that these platforms can also be the bridge between connecting people with similar disorders, similar feelings, and when they can bear out their stories and their vulnerabilities, they will feel understood. And they can also be the motivating factors and the motivation to move on for other patients who are struggling through a similar difficult phase of illness. So there are problems when people get together, and these are issues which need to be sorted out. And a tele-triage is one thing which I really think is a thing of the future. Like we triage based on the COVID-19 risk, and we triage based on the disease, the kind of disease, the severity of the disease, the kind of drugs they're on, how high risk they are. And of course, if it is a follow-up or a first-time consult, so, and then we can decide how, where this patient can go, whether a healthcare worker at the local in the community can help out, or we need a GP, or we need a specialist. So
Yeah.
all of us do our job well and to our satisfaction. And of course, all of this cannot move forward without having patient-reported outcome measures. In fact, I just experienced this last week that now we've been following up these patients for 2 months, and some patients they're doing fine, but you need to know how severe, you need to quantify their disease. So rather than we counting the number of joints that are swollen or how weak their muscles are, we will need to move to patient reported outcome measures. But with the use of smartphones, I hope that will be easy.
Yeah, thank you, Dr. Gupta. That was fantastic. And just moving on to, I wanted to explore a little bit about the home monitoring of patients. So, in the Western world, particularly, now the thinking is that a lot of the consultations are going to become teleconsult. So, it will be a combination of both physical in person visits as well as teleconsults, particularly for reports. And, like you said, those adjustment of medications, so that is one area. But the other area, like you mentioned about, the patients, you doing the scoring. For example, in rheumatoid arthritis, you have that scoring system. Now that is available as an image. So if we can use digital health and technology to have the patient, mark, okay, this joint is this much of pain, that joint is that much of pain. That scoring system is not difficult to digitize. And again, intake forms is another area. We've been using, intake forms which are fillable. Patients fill up in their time and they send it ahead of the appointment. So these are different ways of doing it so that they don't waste their, they don't spend their time. We don't waste our time during the consult going through, their entire history, because some of them have long histories. And like you said, your OPD, there are others waiting, so that is again something difficult. So these are different ways that we use. Another thing is about home monitoring. This is again more kind of health 4.0, like it's in the future. So some of the things we are already able to do, like using wearables to track sleep, movement, resting heart rate, which are all major biomarkers that we are already able to do. But the other problem as a clinician I find is it's a lot of data. I'm not able to manually interpret all that. So that is where, having a computer help me in interpreting that is going to be a big one. Then there are a lot of wearable sensors, like some sensors are already available in use, which can be inserted into the shoes. So for gait and things like that. So it is going to come. The future is exciting, but yes, today we don't have everything, but we still do have some of the things. Then there are, like you described, the challenges of people who are illiterate. So how are they going to fill up a form? So again, voice recognition software and voice AI, those things will also change a lot of things very dramatically, and I'm really waiting for all those things to happen. So thank you, Dr. Gupta. Any last comments that you'd like to add? You can stop sharing your screen now. I think the PowerPoint is over.
Yes.
Yeah.
So, yes, I do think the future is exciting, but in a country with a population as massive as ours and with 400 dialects and so many states and people, everything is going to take time. So, I think we need to start from simple measures like time to walk 2 meters,
Yeah.
time to get up from a chair, time to do 10 repetitions of an activity. Go basic, go simple, and then delve deeper into those outcome measures and see where it takes us. Because, yeah, we need to just understand our patients better.
Okay. Thank you very much. So thank you, everybody. Thank you, Dr. Gupta.
Thank you. Bye.